Okay, we'll move a bit more posteriorly again. Alan, how do I get this to?
You check.
Okay, so yeah, this patient was seen just last month actually, a 29-year-old Chinese lady. Essentially unremarkable history is that she's a high myope at LASIK. So she had a complaint of bilateral central visual disturbance, 4 days duration. Essentially some grey spots blocking the interest, more in the left eye than the right, and this was constant. So this is a scotoma. And based on her history, she did have a ski trip, I think to Korea, and witnessed the sunset, but she was wearing sunshades. And she also had a bout of viral fever with joint aches and rashes, but dengue, which is quite common in this region, the serology was negative. So at this point, we were thinking that these might be the related factors, either obviously one thing to consider solar retinopathy if she didn't have enough protection, or could it be some viral defect? So essentially, vision is 6/9, a bit down on the left. No RAPD, but you can see there's a bit of a yellow reflex here, and it looks slightly paler on the left eye. Okay, so the 10-2 visual fields, normal, no scotoma. Now, when we did the OCT, right eye looks fairly normal. On the left eye, you do see hyperreflectivity over here. It's bad. This was acutely. And on the FFA, maybe we can quickly poll the audience. Anyone finds anything? Would anyone like to comment?
Don't ask me. On your second.
Yeah. A bit, yeah, we shared clear cornea, so we could get through that.
She had LASIK, right?
Yes, she had LASIK too.
There
Yeah.
you go.
Essentially. Yeah, so it looks fairly okay, but the FAZ on this side might be looked a bit irregular, but there was no leakage on the late frame. I mean, we're only showing one frame here, but trust me, there's no leakage, no pooling, and so on. So I thought this was a bit suspicious, but someone else said to me, come on, what are you talking about? But just to show you how perhaps OCT and geography can be helpful. So essentially, at this point, nothing very much, isn't it, other than a bit of hyperreflectivity. But here's the OCT angiograms, where you can see the FAZ is not so regular, and there is a bit of loss of the perifocal capillaries around here, the capillary dropout as well. This is the superficial layer, and on the deep layer as well. And if you look at the right eye, remember she did have symptoms on the right eye, you see some irregularity as well over here, and loss of the capillary dropout as well. Very small, very faint, but that's why I think her vision is her symptoms are not that bad. So just go back. With maybe a bit of 20/20 hindsight, when we could magnify this, adjust the contrast and so on, we might be able to see a bit. But frankly, if it were not for OCT and geography, I think we might have really passed this off as normal actually. So I think this is one of the potential uses where OCT and geography can be very helpful. Is it possible that this is an artifact? The scans were done by me, so don't hurt my feelings. But also, we repeated scans, right? And this is consistent on the same day as well as over time. Yeah. So maybe I'd like to invite the faculty for comments or anyone in the audience.
Giovanni, what do you think?
Well, I actually saw the case, so this is why I was not saying anything. And we saw something this morning that it's exactly the same case. And I don't know, it's kind of, it's interesting to see that, the changes in the vessel. If you go back to the OCT, I think it's the most interesting. I would do the diagnosis based on the OCT. Don't you agree? Yeah. And that actually, it's the change in reflectivity usually is due to change in the perfusion. And because of that, it's probably there is some edema in that layer, and probably that is related to the fact that there was the occlusion of the vessels that you actually see in the OCTs. So I would call it PAM, disease patient, and I would expect recovery quite well.
You're talking about over here? Well, we do know that the temporal choroid can be a bit thicker, but we didn't measure it, but yeah, I agree for high myope, this one. In fact, this is the more affected eye, and it might still be alright. It does change with age as well. She's relatively young, so I think 29 or something.
It looks quite young.
Yeah. So, sorry, with the OCT, oh, you mean just like this? Yeah. Okay, so I'll just repeat the question. Is if I were to look at this alone, would I call this abnormal? I think the short answer is yes. I mean, I stand to be corrected by the rest. But essentially, I think for a young person who may otherwise have no ocular history, I think the foveal avascular zone is usually a bit more regular. It's not a perfect circle or oval, but it's usually more regular. And these areas of loss of the capillaries are usually not very common. We don't typically see this in a healthy eye. But I'm not sure whether the rest of the panel would like to comment.
I would agree. I mean, at this age, you would expect an intact perifocal circle. What do you think is the pathophysiology here?
Well, that's a good question. I think more likely it's some viral foveolitis, perhaps, that may cause some of the some ischemia around the area. Although actually the deeper layers tend to be more affected. We do see it here, but it's a bit surprising that the superficial plexus also shows it.
But it's broken even in the right eye. You see that?
Yes, absolutely. Yeah. And she does have symptoms in both eyes, actually. Yeah.
Did she complain of any photopsis?
Not that, no photopsis.
What was the early phase of the angiogram? Was there a delay in the dye filling? Because the retinal veins on the left eye seems to be a little bit tortuous compared to the right eye.
Good point. I don't know the exact amount, but I don't recall that there was a delay. But I'll go back and check on that. I don't recall that there was anything, but I guess, yeah, I mean, I think our residents sometimes will always start off by reporting the arm delay and so on, but something that we sometimes overlook.
How is the visual field?
Visual fields is fine. Yeah, normal. But however, she does perceive paracentral scotoma. She can draw it out on the hamster, which I didn't get. I was able to scan, but on actual 10-2 and it's not.
Probably if you do a microperimeter,
Yeah, that's an idea. Since cases are saved in PDF, maybe I'll just quickly move on to one more case before we switch back to, because we need to switch laptops and settings. Okay, so all right, no surprises what this is. We did see some images of this patient this morning, but I'd like to just perhaps elaborate a bit more on this. So this is a patient who was noted incidentally on photo screening to have some orange nodules, initially thought to be diabetic retinopathy, but upon coming into our clinics was found, seen by a corneal surgeon actually, so, and diagnosed as PCV, so right. But essentially, so referred to my clinic urgently, and essentially we did ICG and we see polyps on the PTN. So this is our presentation, and you can see the OCT of the polyp, a bit of subretinal fluid as well. This is the fluorescein angiograms, not very much leakage, a bit off from the fovea, but I elected to treat this patient after discussion with PDT with anti-VEGF combination therapy. So this is after treatment. You can see obviously the damage I did with the PDT over here with ischemia. So the question is this case, is the polyp still patent essentially, and what do we do? So, looking at the OCT through the same cut, it's the same section. Perhaps we see a bit of a lumen here, but the PD height is less, and there's no fluid. Patient was asymptomatic. The vision, I think, was 6.7.5 or 6.6. So I did an OCT angio, and so the ICG showed this little hyperfluorescent area. It did look nodular on stereoscopic examination, no pulsation. Obviously, there is a BVM, but on the OCT angio, we do see something over here. So that brings up the question: which one? What do I treat? Do I treat based on its symptoms, the OCT, the ICG, or the OCT angio, or obviously, or a combination of these? Fluorescein actually might be a bit of leakage from that area actually, but again, nothing on the OCT. So essentially, I think perhaps I'd like to get a bit of view. Just to update, this patient just came back, I think, last week actually. So after discussion with the patient, we decided to watch him, and so he was fine for about another 3 months, and then he came back this time with fluid around the polyp again.
that's fine.
Yeah, that's right. I didn't have time to get the images, but it looks, there's more obvious polyp on the ICG. Okay. But I think essentially, the discussion, which sort of elaborates a bit on what I was mentioning this morning, is the role of OCT angiography for monitoring, also the treatment decisions. Are we going to base it on traditionally what we've done, ICG and OCT, or OCT angiography? And I would venture that I think we need a bit of everything. Meaning multimodal imaging to put together the whole picture in order to make a decision. But maybe comments from the panel or the audience.
I think first to comment on cases where you do see the polyp still persistent on the ICG, no fluid leak on the ICG, OCT shows the persistence of that hump. In my experience, if you see fluorescein leakage, it is only a matter of time. That leakage will occur from the persistent polyp. It means that it's not completely thrombosed, and it's certainly still present physically. Now, whether or not the OCT angiogram helps you in making that decision at the moment, I don't think so. And certainly all our treatment paradigms, as far as the evidence goes, the guidance from the trials, for example, all our evidence-based guidelines do not include the use of the OCT angiogram in making decisions. So currently I still use the ICG and the OCT as the primary means of determining whether I should repeat the PDT. I think what you did was reasonable. The visual acuity is very good.
Full fluence.
You know, he was asymptomatic and so on. So yes, observation is perfectly reasonable in this instance. But I think once that you see leakage, even mild leakage on the fluorescein, there is a high chance that you will recover.
Dr. Sarang, any comments?
Absolutely agree.
Rory?
Would you have treated that specific spot only with just a focal feed?
With,
After your full fluence
right,
PDT?
so would I have just done a small spot of PDT here? Yes, that would have been my plan. If
No, but you did the big PDT initially, right?
Right, that was the initial one. So this was
Yes.
what when he first presented.
Yes.
Yeah, so I covered my practice is to cover the BVN as well as the polyps initially.
No, but you saw the scar that it created,
Yeah, that's right.
right? So you know that later on, that scar will increase in time.
Yeah.
So, looking at this slide, would you just do a focal treatment of that spot?
in this case, at this
Yes.
point, yes, that's right. If I were to treat him at this point, yes, we would go for just the spot. And of course, you know, in fact, that was my plan. If he had, I discussed with him and said, well, by right, I would call this a patent polyp. There's
At
no
least the
need.
BVN is already decreased in size already
Yes,
compared to the initial.
yeah, that's right. So
Can you go back to, would you, so you did PDT.
yes,
Why not laser?
That's why.
why not laser?
Yes.
Focal
Um,
treatment.
Focal with laser, not burning, not cooking the retina, just very gentle. I would say
Yeah. So yeah, definitely I agree. It's possible.
far.
It's possible. Yes. I guess with PDT, I guess I'm a bit more
confident.
confident. I feel more comfortable with that. But I do believe I discussed that option with him as well. But warning him of this one, definitely I would agree. This polyp here, I know it's fine. I'm just worried, whether there's
Thermotherapy.
if he has a very bad scarring reaction. So
But I can actually show you a case, a serious case. You don't have to see any changes in the retina. If you
Correct.
start to see some
Mild.
grayish
Stop.
retina, you stop because what you are focusing is on the orange bulge that became brown.
Brown.
Yeah.
That is
Stop.
more than enough.
sure.
So you don't really scan.
Right. Yeah.
Giovanni, do you have any experience with TTT or
almost like a
micropulse?
Well, it's TTT. We did
Yes.
create so many problems because it was quite difficult. Infrared light, it's difficult to manage, and the pressure or release was increasing or decreasing the temperature was a little bit difficult. Micropulse, not, but the laser. As I use the laser, it's kind of micropulse. I will show you. In that case, I will show you an example of a treatment before and after. The color picture, you don't see anything, and the lesion disappear. And you see in color the orange, particularly when you do laser, and you have some lights that retroilluminate the bulge. And when you start to see from orange became brown, you are more than enough. And actually the goal is not creating any changes in the retina, otherwise you don't see any more, and you have to increase the intensity of your laser. So
Well, the problem of TTT, maybe for this one, was it depends on the density of the laser energy you're applying. Remember, they reduced it for Asian, like about 100 or 125 milliwatts per mm. So you can start with 100 treated. And again, what you can do is turn your aiming beam very light so that you can see the change that Giovanni is saying. And it's actually sometimes hard in our darkly pigmented eyes, but you can actually see that change. The moment you finish it, you ask your technician to turn the laser beam on and just look.
Okay.
And you'll see a very faint change, and you know you've treated it.
Okay.
And then when you follow it up 2-3 months later on, the RP changes really, the migration of the thermal damage is not that great. And even if you follow it up after 1 year, the size of the burn is not really that much. In fact, it's almost the same size as a PDT burn.
Roughly,
I think it's a very interesting point, whether we need to treat the branching vascular network or we just destroy the polyp. I tend to look not just on the FA, where the source of leakage, but also looking at the OCT. So if there is fluid where the BVN is, then I would treat the BVN together with the polyp. In addition, there's been also a suggestion that if you treat the BVN together with polyp, there may be fewer polyp recurrence. For those of us who does a lot of polyp, selective polyp treatment, sometimes as you treat, you get polyps on the other side of the net. So if there's opportunity to treat the whole net together, in this type of BVN, when you see looking at there's a feeder in the center and the user pattern, then I think doing a PDT of the whole region may give you a bit more, better control. As opposed to, let's say, a BVN, which is typically a fishbowl pattern, and there's no clear-cut feeder, and it's not really quiet on OCT, then I think selective polyp treatment may be possible. Thank you.
So we need to treat people. I would. This is the big one. And there's one small one here. That's where you should place it. It goes around. That's why I see the you can titrate it so easy. It's almost like 200. You've done TTT. We never tried it. But you have the machine. You would actually BDT, TTT. Thermotherapy. Centrifugal thermotherapy.
So, this case is a patient with diabetic retinopathy or actually with diabetes. And 67 years old male, blurred vision.